Thank you, Dhruvi. So I have been asked to speak about the emerging paradigms in insulin initiation. We'll first start with the current status of insulinization in our country and the glycemic control of our patients. So only as of now, 4 out of 5 Indian people are uncontrolled. If you talk about the diabetic people, and less than 1 in 4 Indians who are having diabetes, they take insulin. Average A1C is 9.2% of the whole country, and there are several studies, and all of them point towards this that the average A1C is something between 8.5 to 9.5. This study was done in around 6,000 people from 369 sites in different parts of the country. So overall, the message is that the average glycemic control of our patients is poor. Most of people are uncontrolled, and many of them are not on insulin. Let's start with a case. So this is a case, a hypothetical case of a patient who is 55 years old, diabetic since 8 years. He is normal weight. He is not overweight or obese. Other parameters are normal. And his fasting sugar is 190, PP is 246, A1C is 9.0%. And he's already on full dose of 3 drugs, metformin, sitagliptin, and glimepiride. So what do you do at this stage? Now, in this particular patient, the patient is already on 3 drugs. A1C is uncontrolled, fasting is high, PP is high. So definitely he should be on the insulin, because adding a fourth drug at this stage doesn't make much of sense. And these are the patients which we often see in our practice, and many times the patients are not very much willing for insulin, and then we start them on some fourth drug or fifth drug, and after few days or few months they again come back, and then we have to add insulin ultimately. And there is evidence to support this, because there are several studies which have shown that if a patient is already taking two OADs or three OADs in full doses, and when you add the third or fourth or fifth drug, what is the advantage that you get in terms of reduction in the A1C? So from this slide, if you can see, after adding the fourth OAD, there was not much benefit. The A1C reduction was rather, there was no reduction, rather the A1C went up. So once a patient is on the full dose of 3 drugs, then adding the fourth drug may not help. The patient has already glucotoxicity. At that stage, we need to give the race to beta cells, and it's best to start the patient on insulin at that time. Now, this is the age-old dictum. So, fixed fasting first is the way we treat these patients. So, whenever the sugar levels are high, we first try to bring down the fasting sugar. If you bring down the fasting sugar in these patients, then the postprandials will automatically come down. This is what was taught to us since so many years, and that is why in such patients who are type 2 patients and who have failed on OADs, we usually start basal insulin as the first insulin, which is a long-acting insulin, which will take care of the fasting, and we presume that after that the postprandials will automatically come down. So these are the guidelines. I'll just talk about ADA and RSDA guidelines, and these two guidelines talk about what should be the dose of insulin to start when you initiate a patient of type 2 diabetes on insulin. When you start basal insulin, the starting dose can be either arbitrarily, you can start with 10 units, or you can start with zero point 0.1 to zero point 0.2 units per kg body weight as per the ADA guidelines. And RSDA guidelines, they ask you to look at the A1C. If the A1C is less than 8%, then start with the same zero point 0.1 to zero point 0.2 units per kg body weight. If it is more than 8, then start with a little higher dose, 0.2 to zero point 0.3 units per kg. And after that, then you keep on monitoring the fasting sugars and try to target the fasting sugars. The fasting sugars of the patient are above 130, then you keep on increasing the dose by 1 unit or 2 units every time you look at the sugars. And if the sugars fall down below 90, then you bring down the dose by 1 unit. Now, when you want to initiate the patient on basal insulin, these are the options that we have. So this is the historical development of insulin. Earlier, we only had NPH insulin. Now we don't use it anymore because it doesn't work for a whole 24 hours. It has a intermediate duration of action. And after that came the long-acting insulins, which are glargine and detimer. Detimer is not very easily available nowadays and not used very often. But among the long-acting insulins, glargine is the one which is the first generation long-acting insulin. And now recently we have the ultra long-acting insulins, which are IDEG and glargine 300. These are the two options that we have, and these are the differences in their profile. So here is the comparison of NPH and glargine. ये point पे चलता है क्या? चलता है point में? अच्छा इसके अंदर ओके वो ठीक है. So if you look at the first 2732. So this is the comparison of the actual profile of NPH, which was the first which was the intermediate acting insulin, and it used to work like this. So the action used to get over by 15-16 hours, and now then after that came glargine. So here in all the graphs, the glargine is used as a comparator. So compared to glargine, NPH had a peak and a shorter duration of action. Then glargine and detemir both had a longer duration of action, but they also had peak. And now ultra-long acting insulins, we have two options, degludec and glargine, and they both have a flat profile and it lasts for 24 hours. So this is the ideal choice if you want to start a patient on basal insulin. Now, what is the mechanism of action? So, glargine 300, it has a very simple mechanism. It is the concentrated formulation of glargine 100, glargine, and that is why in a smaller amount of solution there is more of insulin, and that's why when you inject glargine, the precipitates which are formed in the subcu space, they are smaller, and that is why there is lesser surface area, and the release of insulin is gradual. So this is the mechanism of action of glargine 100. Whereas if you talk about degludec, which is the other option, in that we have the polyhexamers which are like this in a chain, and after injection they are released gradually from the ends of this chain, and that is why the action profile is again slow and prolonged for more than 24 hours in this insulin. So these are the two insulins which are the best options available with us when you start a patient on basal insulin as the initiation. And the advantage of these insulins is that because it's only once a day, you have better adherence. The insulin is able to cover the whole patient for the whole full day coverage. Then the risk of hypoglycemia is less because there is no peak. It's a peakless formulation. Then it doesn't depend on the meal time. Also, you have a flexibility in both the insulins. You don't need to be following the same time every day. Now, come back to our patient. Now, this is the same, case that we discussed earlier. And in this patient, if you want to start insulin as a, initiation, then we must consider the basal insulin for this patient. And the reason for considering basal insulin here is that if you look at his fasting and postprandial, the difference is just 50 milligram per deciliter. So in this patient, if you bring down the fasting to say 100 or 110, then the PP will automatically come down to 140 or 150. And that is why starting with a second generation basal insulin would be the ideal thing for this patient. We can start with a dose of 10 units per day and then keep on monitoring the fasting sugars and gradually up titrate it till you get the target fasting sugar. Can I water please? Pani. So So, there are divergent views here. Oral drugs should be continued, but among those, many people say that sulfonylurea should be stopped. So, you continue with the full dose of metformin, gliptin, and any other drug that you have, but stop sulfonylurea. But if you stop sulfonylurea, then practically you will require either a co-formulation here or a basal bolus insulin here. So that is why many of us continue sulfonylureas and then add a basal insulin in this patient. But ideally, guidelines say that you stop sulfonylurea and then continue the other OHAs. Okay, now uh, this was the case that we discussed till now, but most of our cases are not like this. If you look at the Asian Indian phenotype, we are known about some peculiarities that we have. We have a thin fat Indian profile, so we have higher amount of visceral fat. Though our BMI is normal, most of the people, but they are still obese, viscerally obese, and that's why we have a lower threshold for BMI, higher fat mass, we have lower muscle mass. There are several genetic factors, and most of us have a low birth weight. The average birth weight in India is just 2.5 kgs compared to more than 3 in the Caucasian population. We have a higher insulin resistance. We have abnormal adipocytokines. We have higher inflammatory markers. We have the characteristic dyslipidemia, which has got high LDL and low HDL. And we have early decline in beta cell mass. So that's why it's said that we develop diabetes at a decade earlier compared to the Western population, and we are at a higher risk of diabetes complications. So many times you will see that the profile is not like the one that I shared earlier. Now it's the same case. All the parameters are same. The only difference here is that the fasting sugar is 164 and the PP is 276. The A1C is same. Now the only difference that I made in this case is that there is a huge difference between the fasting and the PP. So in this patient, if you start basal insulin, you might bring down the fasting to 100, but still the PP will be 210. So that's why in this case, particular case, it may not be enough to give only basal insulin. So the insulin initiation, when you start it, I think the most important parameter other than A1C is to look at the difference between the fasting and the postprandials. And that postprandial may not be the only single postprandial, but you better look at the post breakfast, post lunch, and post dinner. Uh, Even better is to go for a CGM profile, and from that profile you get a better idea which is the ideal insulin to start and that, in that particular case. Now, these are a few, the realities about Indian population. Most of us do spend around 16 hours of the day in a postprandial phase because we take early breakfast when we get up and we take our dinner at around 10, 11 p.m. So that is why the whole, two-thirds of our day cycle is spent in the postprandial phase. And also our diet is very high in carbohydrates. This was a study which was done in whole India, and it was found that in different parts of the country the average carb content of our patients is more than 60%, and that is what is translating into the high HbA1c, high fasting, and high ppg in our people. And also there are some studies which show that at the equal amount of or identical carbohydrate load, if you compare the postprandial peaks among Indians or South Asians and compare that with Caucasians, we have a higher amount of postprandial peaks. So this was the study which showed that I have 3 minutes more, right? Okay. So this was a study in which they compared two population and they had the identical carbohydrate load, but when they looked at the postprandial peaks, the postprandial peaks were higher in the Indian population. Same thing being represented here. This is the difference in the glycemic response in Asian and non-Asian people with type 2 diabetes taking basal insulin. So because of that postprandial peaks which are higher in our patients, if you initiate a patient only on basal insulin, in Asian people, 40% will achieve their fasting target compared to the non-Asians, in which the number of people achieving the targets is higher. So that is why basal insulin may not be sufficient in most of our patients, and there comes the role of a co-formulation. So in these patients, you can go for a co-formulation which has got ultra long acting degludec, and along with that, it has got a short acting or fast acting insulin also. So this is the co-formulation where you have 30% short acting or rapid acting aspart and then degludec, which is 70%. So if you use this insulin, you might be able to use it only once a day if a patient has got a major meal in which the carb intake is high. So at that time, if you initiate this insulin, then the aspart component will take care of the postprandial and the degludec will take care of the fasting. But if the patient has got two major meals, then you can start it twice a day. So once you start this, then this is the way you can, target or up titrate or down titrate the doses. If the fasting remains above target, then you increase the dose by 2 units. If the fasting is at the target, maintain the dose. If fasting falls below 90, then you reduce the dose by 2 units. You start arbitrarily with 10 to 12 units with the major meal of the day. And if the patient and you just monitor fasting in that case. If the patient is taking two major meals with two meals in which the carb load is very high, then you start with twice a day dose, and then you monitor the patient's pre-breakfast and pre-lunch sugars. You give the dose at pre-breakfast or pre-lunch depending on which meal is high, and monitor the pre-dinner value for titrating with dose, and then you take a pre-dinner dose and monitor the pre-breakfast value for titrating the dose of that insulin. Now, just last two slides. With the recent advantages like advances like CGM that we have, like this is an example of one case. So in this patient, you see this CGM profile here. The patient's fasting is somewhere around 160, 170, and PP is high, and that's why his whole sugar levels are high throughout the day. But there is not much difference in the fasting and postprandials. So here, if you just give one basal insulin, the fasting will come down and then the PPs will automatically settle. And compare this with, I don't have the ideal CGM profiles because I just took down last night to give the concept that how you can use a CGM for identifying the right type of insulin for the patient. In this patient, if you see the fasting is not that high, but the postprandial peaks are very high, and the patient has got two peaks. So in this patient, this was a practical case where Ryzolic was started, the co-formulation, and after giving the co-formulation here, you will see that there is a blunting and the fasting as well as postprandials both come down. So having a look at the CGM profile, it gives us a better idea. If you see only small peak at the postprandials and a moderately high fasting, you might just start with a single dose of basal insulin. But if you see that the fasting is high, but postprandial peaks are even higher, and the gap is much. Then you start a co-formulation in that patient. If you see that there is a particular meal which has a bigger peak, you start with 1 dose of co-formulation. If you see that there are 2 peaks, then you can start with twice a day co-formulation. So, okay, my time is up, and there are some cases where you need to up titrate. These are the cases where you start only basal insulin, and then you see that the A1C is controlled, fasting is A1C is not controlled, fasting is okay, and PP is high. So that is a case where postprandials are not controlled. You probably shift to a co-formulation. And I'll skip this part. uh, the major problem is to initiate insulin, to convince the patient to start on insulin. And I can only say that if you spend more time in addressing the patient's concerns about insulin, then we can be more able to convince the patient, because we might have learned the whole theory of how to initiate insulin, but if you don't explain the patient or convince the patient, it will not be of use, because the patient will just take your prescription and go to some other doctor and ask for oral tablets. So I'll just end here for the shortage of time. Thank you.